Hello and welcome from Thessaloniki. This is our second webinar, and this is another webinar with the theme of Keratoconus. Today I'm really happy that I have with me eminent speakers from all over the world. I have Professor Renato Ambrosio from Brazil, Professor Damien Gattinel from France, and Professor Cosimo Mazzotto from Siena, Italy. And with me is also Dimitris Sakelaris, my friend and colleague from Ophthalmica Clinic in Thessaloniki. We will talk and simply pass some messages regarding diagnosis, regarding making awareness of keratoconus in the public, and also on the current improvements that we have in some aspects of treatment of keratoconus. So I will start straight with my friend Renato Ambrosio. I have prepared something in Brazilian. I'm a bit shy to tell that, but all I can tell you is that amigo do Brasil, flaminista, fanático, and enthusiast in the Kera-ring. Thank you very much, Renato, for being with us, and you can start with you.
Thank you, Miltos. Thank you very much. It's a pleasure to participate. I'm sorry I don't speak Greek. I hope you can see my slides. Is that okay? So my topic is the Violet June campaign on public awareness for keratoconus and the 2020 paradox. The Violet June campaign has two very important messages. First is that eye rubbing or scratching the eye aggravates keratoconus and may even cause ectasia. Those are two different things. And also that misinformation may make the patient and their family suffers more than the disease. So it's important that we understand we have started this campaign a couple of years ago in Brazil, and we have this campaign because of the great support from some of the companies that I have collaborated with over the last years. So I thank them very much. I have also to collaborate my friends in Brazil and in Portugal, and also the Brazilian Artificial Intelligence Study Group that is completing 10 years this year. So when you think about ectasia, it's not a new disease. We have understanding about keratoconus described in the literature since 150 years ago over that by John Nottingham. But it was when we started doing refractive surgery in the mid-80s that we saw a huge jump in the number of publications in the literature. So we broke paradigms, but we created paradoxes related to keratoconus. The role of refractive surgery is in fact paradoxical, if it's an ally or an enemy, because refractive corneal procedures can weaken the cornea and progress keratoconus or corneal ectasia. But the diagnosis has evolved, the clinical and the surgical treatment has evolved. However, we have to understand what we are trying to screen for and what we're trying to do when managing patients with the disease. Understanding ectasia susceptibility, diagnosing ectasia, staging the disease, and follow-up are different aspects of the use of multimodal corneal imaging. We are overwhelmed with data, and understanding the data is challenging. That's why the revolution in evolution or artificial intelligence is related to the understanding of the diagnostic approach for keratoconus diagnosis and management. For example, when we screen for ectasia susceptibility, like in this case with 2015 distance correct vision, you can see 0.78 of a TBI, which integrates the Pentacam and Corvis with artificial intelligence using random forest index. Interestingly, this is a publication that was published in 17 in the JRS, in which we looked at the very asymmetric eyes, patients that have normal topography based on a strict objective criteria that had 90.4% of normality. And those cases will be something that we call an epitomize of ectasia susceptibility. Interestingly, ectasia susceptibility can be found in just unilaterally in one eye. For example, this patient has unilateral ectasia. We published with many esteemed authors like my friend Damien Gattinel. This patient was followed up after having a great result in the right eye with a Kera ring, He moved to London, and Damien Gatinel score analyzer along with Alan Saad was done by Dan Reinstein's clinic in London, in which epithelial mapping and everything, including the TBI, was normal. So this is a unilateral ectasia, not keratoconus. Interestingly, patients like that with 2015 with fellow eye that is abnormal on the TBI, in which the fellow eye has mild keratoconus. So when we see those very asymmetric cases, the fellow eye has to be understood beyond, not over the surface of the cornea, so that we understand if the fellow eye is a true form fruste or a true unilateral case. And I come with the wisdom of Yoda that true unilateral keratoconus does not exist. However, you can have ectasia unilaterally due to a mechanical process. That's why we talk about the understanding that eye rubbing can eventually aggravate keratoconus or even cause ectasia. Those are two different things. Importantly, we have to understand treatment of a keratoconus. Treatment for keratoconus today is based on diagnosis, evaluation of the clinical and education of the patient, and surgical treatment. When we talk about treatment, patients should be understood. Education is fundamental. Allergy control, guidance so the patient don't rub the eye, and this is some video from the YouTube that is called the eye rub. A riboflavin-rich diet and other clinical treatments may be even attempt, and we do believe that the B2, along with omega-3, can help the patients do much better for preventing keratoconus progression and optimizing ocular surface. This is, in fact, one of the things that we had 100% consensus that the importance of eye rubbing is unquestionable, so that we have the duty to tell people not to rub the eye. And I'm sure Damian Gatinel will be even more emphatic on this message that eye rubbing is a sine qua non for keratoconus. This is part, but not the only main message of the keratoconus violet June campaign. We have to tell people not to rub the eye, and that's the advocate of Violet, our main character in this book. And we have to tell patients also about the disease. People are really afraid about having a transplant, even though the transplant is the best transplant we have in medicine. We evolved from penetrating to lamellar keratoplasty with a deep lamellar surgery, like this beautiful procedure by Frank Price, in which you have a very deep lamellar dissection. And also we can use the femtosecond laser for this approach and having a better result in terms of wound adhesion. Surgery for keratoconus is to halt ectasia progression and for visual rehabilitation. Is not a refractive procedure. Refractive procedure and therapeutic procedure should be understood as different procedures. Even though, like a lion and a cat, they share a lot of similarities, they are not the same. Very importantly, we have cross-linking. Corneal cross-linking was first described in the mid-90s by Professor Seiler in his group, and eventually it broke a paradigm, it changed the way we treat keratoconus, because now we have the ability to halt disease. However, when to do it is important. So you need to have diagnostics to understand the follow-up and eventually do the surgery with less harm. As Milton just described, I am very enthusiastic about the Brazilian ring, the Kero ring, and the Ferrara ring. We have the Brazilian history very nicely described by my friend Alexandre Paratella in this channel in the internet. We have many techniques for intercorneal ring implantations, and that's the only technique that I think it's exclusively should be done with the femtosecond laser. And having experience with over 10 years with the femtosecond laser, that's the most important indication for this procedure. The corneal ring has improved, and we have asymmetric rings. And why do we have asymmetric rings in the thickness that is progressive? Because we have an asymmetric disease, like in this case. Importantly, the paradox of keratoconus is that it's a new subspecialty in ophthalmology. We have broken paradigms. We have paradoxes because when you should do surgery, you should do as soon as possible. But if you don't need the surgery, eventually you should not have it. When, why, and how to treat patients with surgery. Every patient should be individualized, and so that we understand the patient's needs. Excuse me. The role of artificial intelligence is very unquestionable. However, when you think about individualized medicine, The paradox is that with patient education, we still must to do the humanized medicine with a medical mission to heal few times, relieve often, and comfort always. I'm very happy to be here and looking forward to the discussion about keratoconus management in the Valley June. Thank you very much for your kind attention.
Thank you very much, Renato. And I think it is a great job that you're doing in Brazil. Of course, you had a fantastic experience in the US for many years, and what you're doing both in Brazil and in ISRS for the diagnosis of keratoconus, but for the awareness as well of keratoconus is very important. And I would like to share that we have translated the booklet, the Violent June, in Greek, and hopefully we will do another campaign, a stronger one, the following year to support, to make open, public, and aware. And I will try personally to get the press involved on that. It's very important. Awareness is the key for the keratoconus. The earlier we can treat them, the better. And of course, you're a virtuoso of Kera rings, and one of the future meetings we will talk about that as well. Thank you very much. Dimitri, you want to present Professor Gatinel.
Bonsoir à Paris. Professeur Gatinel.
Oui, bonsoir, ça va? Ça va bien.
Bonsoir à Paris.
Bonsoir, bonsoir à Thessalonique, ça va?
Nous avons l'honneur et le plaisir d'avoir parmi nous professeur Damien Gatinel, un vrai gourou sur le sujet de Keratokonus. Merci bien pour avoir accepté notre invitation.
Merci.
Je crois que je suis le seul qui parle français à notre clinique, donc j'arrête. I switch to English and I give the podium to you. It's all yours.
Yeah, thank you very much for inviting me. I'm very pleased to be here. And so, as we decided, I think you can launch the pre-recorded video, or you want me to do it? Yeah, perfect. Thank you.
I would like first to thank the organizers for inviting me to present on this very important subject. I have no financial interest in eye rubbing. I wish to thank all my collaborators. In my opinion, excessive eye rubbing is very dangerous because it is the necessary cause of keratoconus and not just an optional risk factor. Eye rubbing is caused by general or local factors, and corneal resistance varies from subject to subject. Keratoconus occurs when the energy delivered by friction exceeds the natural resistance capacities of the cornea. The apparition of a permanent deformation results from the imbalance between the mechanical stress and the resistance properties of the cornea. This conjecture is summarized in the formula no rub, no cone. There are various reasons why patients rub their eyes too much: dry eye, allergies, screen work, and many more. There are also many ways to rub your eyes in terms of style, intensity, and duration. Using the hardest parts of the hands and fingers is certainly more dangerous. Visiting social networks and keratoconus patient groups is very informative. This can lead to awareness of certain things and suggestions for us, eye doctors. While eye rubbing is still reported as a risk factor in the literature for keratoconus, it is also a risk factor for most of other risk factors of keratoconus. This logical fallacy makes eye rubbing a good candidate for a cause and effect relationship to keratoconus. In 1965, the English statistician Sir Austin Bradford Hill proposed a set of 9 criteria to provide epidemiologic evidence of a causal relationship between the presumed cause and the observed effect. That can be useful in establishing epidemiologic evidence of a causal relationship between a presumed cause and an observed effect. Through this presentation, we will see that the hypothesis no rub, no cone satisfies these criteria. As an example, let's focus on the 4th criteria, which is particularly important. When we question patients with keratoconus, we observe that in all cases, rubbing precedes the appearance of keratoconus by months or years. These actions are sometimes neglected or ignored, which explains why a small proportion of patients say they do not rub, at least at the first visit. In our experience, once awareness of possible excessive rubbing is raised, it is acknowledged by nearly 100% of patients during the second visit. This patient realized that he was rubbing his right eye harder, and we can safely assume that this explains the more pronounced character of the corneal deformation on the right. In the same vein, it is therefore tempting, even if a little presumptuous, to think that these articles published in 2016 and 18, respectively, could explain the recent boom in publications devoted to the study of the impact of eye rubbing and its exact responsibility in the genesis of keratoconus. These publications, this article has just appeared, which reviews the genetic versus mechanical causes of keratoconus, and which concludes in the existence of purely mechanical pathologies, but which could coexist with different forms of a genetic origin, which is a paradigmatic reversal if we refer to numbers. The cases of keratoconus are overwhelmingly sporadic. In another recent study, we found that eye rubbing with the knuckles was the most important predictive factor for keratoconus, while the presence of a family history was not significant. Another argument argues in favor of an external factor for the genesis of keratoconus. If keratoconus is genetic, it should always be bilateral. Thus, the existence of truly unilateral forms is debated. Do they really exist? We believe so. Here is an example. The right cornea is affected by keratoconus, but not the left cornea. Negative for all topographical and biomechanical indices of detection. It seems, after almost 15 years of follow-up, that this keratoconus persists in remaining strictly unilateral. This is evidenced by the stability of the score and the differential map over 15 years. Obviously, the existence of strictly unilateral rubbing gives credence to the mechanical hypothesis, all the more so as the stopping of these from 2006 made it possible to stop the progression of the deformation on the right side. Here are 4 genetically identical eyes raised in the same environment, but only one of which has been excessively rubbed. A single case of such twins discrepancy is sufficient to demonstrate the need for external factors. Studies show positive family history in only 6 to 25% of the cases. Of course, there is a genetic dimension in keratoconus, but in our opinion, it is indirect and concerns the degree of corneal resistance or the susceptibility to allergies and all the factors that encourage patients to rub their eyes. The next question should be, why the right eye and not the left eye, or vice versa? We have discovered that in unilateral or very asymmetric forms, the most affected eye is always the most or the only one rubbed, and its side is highly correlated with the side of a stomach sleeping position with prolonged compression of the orbit. Here is an example of a very asymmetrical or even unilateral keratoconus. The picture of the sleeping position was taken by the mother of this patient, who rubbed almost only his right eye. Here is another example, very similar. It is questionable whether this type of keratoconus could only be the consequence of a bad sleeping position, causing chronic eye irritation, and subsequently the need to rub to soothe it. Another important criteria is plausibility. The corneal resistance properties can be reduced by eye rubbing itself, and this is a mechanical route to keratoconus. But various biological mechanisms and enzyme cascades have been described in healthy volunteers who rub their eyes. Indeed, there is also a parallel rubbing-induced biological route to keratoconus. But that's not all. Until today, little was known about what happens to the globe when it is rubbed. We acquired dynamic MRI on a healthy volunteer who was asked to rub his eyes. These images speak for themselves. Chronic eye rubbing is compatible with the focal damage of the apical stroma, where researchers demonstrated, using Brillouin measurements, that biomechanical alterations were primarily concentrated. Beyond the corneal distortion, the movements of the globe, which steps back into the eye socket, are truly impressive. It is not surprising that cases of IOL subluxation, hyphema, glaucoma, and retinal detachment have been attributed to excessive eye rubbing. Here is a case of a chronic eye rubber, which caused a marked focal thinning of the cornea. Careful examination of the irises reveals the presence of a lower depigmentation with delamination of the iris stroma fibers. This condition is called iridoschisis. The very inferior location of the corneal and iris damage is probably linked to the area of impact of the rubbing, which could be the consequence of the gesture and the intensity of the bell phenomenon, in this case, a marked higher rotation of the globe. I have presented extreme and remarkable cases. What is also remarkable with keratoconus and echoes the fifth criteria is that there is a continuum between normal and very deformed corneas, with intermediate situations for which it is difficult to decide, keratoconus or no keratoconus. There may never have been a keratoconus in the sense of a pure genetic affection, but a plethora of topographical patterns conditioned by the severity of the lesions inflicted by external mechanical phenomena, daytime and or nighttime rubbing and compression. In the case of inadvertent topographic discovery of these early forms, rubbing is typically recent or much less vigorous and frequent. This continuum and correlation between gesture and severity of the deformation also vehemently pleads for an external cause. In other words, the extreme variability of the topographic presentation modes of corneal deformation is matched only by the extreme variability of rubbing in duration, intensity, and frequency. In summary, the Norrob-Narcone conjecture meets the Bradford-Hill criteria. There is ample evidence that keratoconus requires an interaction with environmental factors to make a genetically determined predisposition manifest as a phenotypically apparent disease. This is where eye rubbing comes into play. We can assemble all these pieces of information to solve the puzzle of the pathophysiology of keratoconus, where eye rubbing, often associated with eye compression related to sleeping position, is a sine qua non. Finally, let us recall that the study of Marfan syndrome teaches us counterfactually that a soft but not rubbed cornea thins and flattens in a homogeneous and non-focal fashion. Therefore, it seems there is no way that the morphological changes seen in keratoconus could appear spontaneously in a weak but non-rubbed cornea. Beyond the academic debate, refusing to admit the causal and essential role of excessive rubbing deprives us of the possibility of halting the progression of the disease or even eradicating it by educating patients at risk, particularly allergic or prone sleepers. I hope I have convinced you of the urgency to completely revise our understanding of keratoconus. Today, our care for keratoconus patients is fully dedicated to making them stop rubbing their eyes, which is not easy and requires a comprehensive approach, but that's another story. Thank you.
Thank you very much, Damien, for this really complete new theory, which I have followed for the last years, and it's really adding up or clearing a lot of questions that we had in the past for the inflammation, the mechanical causes, and of course, in some unusual cases that we really don't know how to deal with them. I think it's another beautiful box unrevealed in this fantastic puzzle of cross-linking. Dimitri, do you want to add something on that?
You're muted.
Sorry?
Dimitri is muted, I think.
It's muted. Okay. Okay.
Now?
Nene?
I think that every specialist that seriously is on the keratoconus subject, the first thing we do in our practice is to ask our patients if they're rubbing their eyes. Even if we accept it as a whole theory or the holistic theory about the origin or not, we do have it in our mind. We always ask our patients if they do it, how they do it, the pattern that they follow. You showed something very interesting about the eye rubbing during the sleep, which is very sometimes it slips us. It slips away. We don't pay attention to that, and we always say to our patients after, no matter if we apply a cross-linking treatment or not, to stop rubbing their eyes. It's very crucial, not only for the progression or not of the disease, but also for the success of the cross-linking treatment.
Mm-hmm. Yeah, I think that's the way to go.
I think Damien also, I don't know if you can hear me. I think also this adding this extra protection that we have for the inflammatory aspect of keratoconus, and apart from anything else that we're doing, either on cross-linking, rings, or whatever we want to do to formulate a better surface, we have to treat the underlying inflammation, and we have to teach the patients as well to stop or to forbid them somehow giving another cascade of inflammatory reactions from my rubbing in an eye which is already red, inflamed, but we're missing this picture because we look at the topography first and we're missing a lot of other aspects. I think it's very important to treat the inflammation in keratoconus as well as in dry eye without obviously forgetting all the other aspects that we have to do in this area. And for this, I have to thank you because you made a strong contribution. You raised this voice for many years on that, and it is really very important. Renato, you want to add something on this?
Yes, thank you for the opportunity. I highly agree with my friend Damien, but I remember when I was in medicine, we learned from the French medicine that la médecine c'est comme l'amour, ni jamais ni toujours. So I do agree that eye rubbing is very important, and it's the main message that we have to conceive to the public. And also I believe that you are right on the inflammation. Farhad Hafezi has done a very nice study on the eye rubbing model with in which he pretty much demonstrates that eye rubbing does not weaken the cornea, at least an intense eye rubbing in that intensity that he did. But he was using an ex vivo model. It was no inflammation was involved, and also the temperature of the body, all the factors that are related to the inflammation were not there. So I think it's much more on the quest for the mechanical trauma in terms of the inflammation. But I highly agree, we should focus on what we all know that is very important, that eye rubbing is evil for patients with keratoconus, and eventually stopping eye rubbing will definitely decrease the suffering from the disease in the world.
Great. Yes, I would like also to thank now, and of course at the end again, our sponsor, Ophthalmica and Avidro, for this fantastic webinar, which will make the next presentation even more interesting, because it will link the eye rubbing that we have seen, and we link the keratoconus with the inflammation. So I would like to present Professor Cosimo Mazzotta's lecture, which is videotaped. Unfortunately, he's on his way to Siena, but there is a stuck traffic, I think, somewhere outside Rome, so he cannot listen to us. Hopefully, if he can make it at the end, it will be great, but we have his lecture, and we will continue with that.
Στο νέο KXL έχουμε προσθέσει μια οθόνη αφής υψηλής ευκρίνειας, η οποία είναι μεγαλύτερη από την προηγούμενη έκδοση. Το λογισμικό επιτρέπει τροποποίηση των πρωτοκόλων και σύνταξη γνωμάτευσης, η οποία μέσω USB μπορεί να μεταφερθεί στον υπολογιστή σας σε μορφή PDF για αποθήκευση και εκτύπωση. Το KXL της Avedro επιτρέπει στο χειριστή να πάρει τα αποτυπώματα του κερατοειδούς και με βάση αυτά να κάνει εστιακές εφαρμογές σε περιόδους ακτινοβολίας ακριβώς στα σημεία που έχει ανάγκη ο κερατοειδής. Μελέτες που έχουν γίνει με βάση το KXL σημειώνουν σημαντικά αποτελέσματα στην αποπλάτυνση και επιπέδωση του κερατοειδούς μετά από cross-linking, καθώς και την αλλαγή στο διαθλαστικό αποτέλεσμα. Με άλλα λόγια, οι ασθενείς μπορούν ταυτόχρονα να σταθεροποιήσουν τον κερατόκονό τους και να βελτιώσουν την όρασή τους. Οφθαλμίατροι με εμπειρία στην πάθηση του κερατόκονου και στη διασύνδεση κολαγόνου υποστηρίζουν ότι τα αποτελέσματα της επέμβασης μετά τη χρήση του KXL είναι απολύτως σταθερά, με το 99% των ασθενών να έχουν σταθεροποίηση του κερατόκονου και αλλαγές στο διαθλαστικό σφάλμα για τα πρώτα 2 με 3 χρόνια.
Good evening. Thank you for this kind invitation. Thank you to Miltos Balidis. It is an honor for me to be with you, with Renato Ambrosio, with Damien Gatinel, with Dimitrios Sakellais, with Miltos at this second Keratoconus Day online meeting. I will speak about keratoconus progression in patients with allergy and elevated surface matrix metalloproteinasis. The correlation between allergy and keratoconus was reported first by Hilgartner in 1937 and was well known. There are a lot of evidence actually that changed the paradigm of the keratoconus old definition as only a degenerative disease. We know that such results suggest like Charles McMahon has also demonstrated, that keratoconus cannot be defined only a non-inflammatory degenerative disorder, but in the pathogenesis of the disease, a lot of factors such as traumatic factors and chronic inflammation events could be involved in the development and the progression. We have a lot of evidence of inflammatory processes just published in the literature, both in contact lens wearers and non-contact lens wearers, in atopic and allergic patients, in patients suffering from blepharitis, rosacea, and rubbing-related corneal traumatism, degradative enzyme hyperactivity, and tear dysfunctions, dry eye, meibomian gland dysfunction, the evidence of reduced anti-inflammatory capacity of the tears, indicated in keratoconus with the reduced lactoferrin level, lipofilin A and C level, the reduced immunoglobulin, and increased the albumin in the tears, suggesting failure also of the blood-ocular barrier in the conjunctival vessels with the typical hyperemia of the conjunctiva, the typical photophobia, extreme photophobia of these patients who rub a lot their eyes. There is a very interesting review from my friend Robert Wiese. It was published in the Ocular Surface in 2015, showing the higher level of metalloproteinases, in particular the 9 in the tears, but also in the epithelium of these subjects with reduced levels of the disease oxidase 2 enzyme and the family of disease oxidase enzyme in all corneal level layers, and the increase of pro-inflammatory factors such as interleukin 1 alpha and 1 beta, and also the increase of pro-apoptotic effect of interleukin 1 with the tumor necrosis factor, and also the increased level of metalloproteinases. What we want to say is that there is a model of interaction between soluble inflammatory mediators, keratocytes, causing stromal collagen remodeling that is typical of keratoconus, with stromal volume depletion, slippage of collagen, deformation of the corneal profile, and also the stromal thinning. Of course, I think that always there is a genetic susceptibility, and the environmental factors such as eye rubbing increase the overexpression and concentration of soluble immunomediators, binding receptors of stromal keratocytes, thus increasing the protease activity after rubbing, allergy, inflammation, chronic inflammation, stimulating keratocytes, interleukin apoptosis, and also the transforming growth factors may induce differentiation of keratocytes into myofibroblasts and the transformation to fibroblasts with fibrotic phenomena, and the other biomechanical and biochemical modification stimulating extracellular matrix in the complex of collagen proteoglycans, remodeling the tissue distribution with slippage of interlamellae, and the volume depletion with the classical thinning of keratoconus. So it has been proven clearly that eye rubbing increased level of tumor matrix, metalloproteinases, interleukins, tumor necrosis factor, even in normal subjects, contributing to the development and the progression of keratoconus, like in the studies of Balasubramanian and Wilcox that was clearly demonstrated. Also, inflammation keratoconus, it has been proven acute and post-acute corneal eye drops in pediatric eye rubbers suffering from allergy. So we know it is clear that allergy and eye rubbing promote and accelerate keratoconus progression. It is in particular evident that the 1-year progression rate that was reported by Schatzi and Afezi in the literature of 88% of progression in pediatric population of keratoconus becomes 100% in 1 eye in allergic patients suffering from allergy and eye rubbing. So I have published an interesting work in Eye and Contact Lens in 2017, showing the keratoconus progression was higher in allergic patients with eye rubbing and elevated surface matrix metalloproteinases that were measured by a point of care test. You know that it is inflammatory. I don't have any financial interest, of course. We studied 100 patients in stage 1-2 keratoconus, dividing them into groups. The first group of 52 patients was positive to analysis for allergy, rhinitis, allergic conjunctivitis, asthma, and various associations. And 48 patients were non-allergic at anamnesis. And eye rubbing was found in 100% of the allergic group, and in 16% of the non-allergic group. The inflammatory test positivity was 81% in the allergic group with keratoconus, and only 4%. And the 4% of non-allergic were eye rubbers, of course. So we excluded from this study the dry eye patients with OSD test. We excluded from Schirmer tear test, and also with non-invasive breakup time testing. We graduated also the papillary subtarsal hypertrophic response from absent to high, and of course we tested the metalloproteinases. The normal level range in the tear film of metalloproteinases are between 3 nanogram per milliliters to 14 nanogram per milliliter. So this is the RPS test from Sarasota. There is a direct sampling microfiltration test, and the positive test results indicate the presence of metalloproteinases number 9 on tear fluid over 40 nanograms per milliliter. So what we showed with the black line that represent the allergic group, that we have an higher progression, a visual decay that worsened better in most importantly in the allergic group compared with the non-allergic. Also Kmax increase tremendously in these allergic patients with contemporary corneal thinning, and also the eye gourd aberration, particular coma-like aberration, increased contemporary in allergic patients, and you can see here the red arrows. Another important correlation test appears and showed that in the graphic A here, the highest correlation between Kmax increasing and corneal thickness reduction was shown particularly in the keratoconus allergic group with a Pearson value test of minus 0.85. And the box plot testing showed that maximum increase of Kmax is correlated with the highest hypertrophic papillary subtarsal response recorded in the keratoconus allergic group. Indeed, the test showed that the increase of Kmax was greater in box 3 and the box 4 corresponding to keratoconic allergic patients with grade 2 and 3, so the higher grades of the hypertrophy papillary subtarsal response. We did also the exact Fisher test, the tailored Fisher test that showed the correlation between the positivity between the inflammatory test and the eye rubbing, confirming that a statistically significant value from the correlation between eye rubbing and the positivity of the MMP9 point of care test in patients with keratoconus and allergy. So the association between pediatric age allergy and eye rubbing may represent, of course, a dangerous situation, stimulating a really faster progression. And take into account also that patients who tested positive to MMP9 test in the keratoconus non-allergic group belongs, of course, to eye rubbers. So the study demonstrates that a concomitant allergy may increase keratoconus progression, especially in severe untreated eye rubbers cases. And I also showed this in my publication of 10 years results in cross-linking in pediatrics, where the 4.2% of retreated patients belongs all to eye rubbers allergic patients. So to take home message, we need to highlight the higher potentiality of ectasia progression in pediatric patients suffering from allergy and rubbing by providing appropriate screening and improving care for atopy and allergy. We need to stress the importance, of course, of cheesing eye rubbing, like Renato Ambrosio stressed, and also Damien stressed this concept very well. We need to close tomographic corneal monitoring to eye rubbers and allergic atopic patients, children in particular, for the risk of ectasia development, progression, eye drops, and performing cross-linking without awaiting further progressions. And we need to manage, to recognize and manage allergic conjunctivitis with topical antihistamine and mast cell stabilizers, steroids, preservative-free lubricants, and also cyclosporin A may be used in severe cases of giant papillary conjunctivitis or in vernal keratoconjunctivitis patients. So we need to alert pediatricians and ophthalmologists for yearly keratoconus screening in the eye rubbers allergic young patients. I thank you for the attention.
That's another excellent presentation, clearing out even more the situation for the inflammation and the eye rubbing. We have a couple of questions that I would like to discuss now. Maybe Damien can be with me. We have a question on the use of corticosteroid drops in allergic cases, and they ask if there's any evidence that we can contraindication of steroids with keratoconus. What do you want to comment, Damien, on that?
Yes, we use, if there is a indication because of local ocular surface inflammation, or if we believe that corticosteroids are a good adjunct to the therapy, and that's a cherry on the cake, but the cherry is bigger than the cake, have the patient stop rubbing, then we would use them. We regularly also use cyclosporin, topical cyclosporin, in some patients who have lots of allergies, and that also may be interesting for treating both the inflammation and sometimes the dryness of the eye. So I think it's a very nice armamentarium we have with this molecule as well. So we give patients everything from tears, local gels, ointments, steroids, and also anti-allergics, and cyclosporin.
Good, yeah. And there is a question of how quickly keratoconus can be escalated. I think certainly the allergy and the sudden has a cause, and the sudden development of keratoconus. Of course, allergy can escalate keratoconus, and eye rubbing can escalate keratoconus. This is something that has been proven and shown to you really elegantly. I don't think that there is any point of that. And there is the last question, again, I think is for you. How confident we are that eye rubbing causes keratoconus? I think we are very confident on that. And not some changes in the corneal collagen. Secondly, in what percentage can we say with certainty that eye rubbing is ultimately what causes keratoconus? And thirdly, does eye rubbing cause keratoconus, or does keratoconus cause eye rubbing? Okay, Damien.
Yeah, come on. I mean, for the last, I will start. That eye rubbing causes keratoconus is like you ask me if you press on something, this is the something which causes the pressure. I mean, seriously, when you interview patients, they rub way long before they have the first visual signs of keratoconus. So if you have a logical mind, and if you have a bit of proper thinking, I think in the most cases, because rubbing precedes keratoconus, the cause is the rubbing, and the consequence is the keratoconus. Now, the second point was in what percentage? This is where we disagree among keratoconus specialists. In my opinion, 100% of keratoconus is caused by some local repeated trauma. I always take the example of UV light and sunburn. I mean, there are risk factors like a light skin or going to the beach, but if there's no UV, there's no sunburn. there's no local trauma, there's no cone. And a good argument for that is the Marfan syndrome. That's where I changed my mind, because as every one of you, when I was as a student, I was reading Keratoconus and I would agree on what it is. But the problem is that if you have a soft collagen, then Marfan is a case where if you believe that softening the collagen is enough, you're wrong, because the soft collagen is the cause of the Marfan cause, flattening and thinning. Most inflammatory situation in the cornea without eye rubbing is causing not a stiffening, but usually a flattening. Post-traumal inflammation, herpes, deciform post-keratitis, herpes zoster keratitis, scars. All these things, when you look at it, it's a flattening, not a stiffening and a thinning like in Keratoconus, you see. So Keratoconus is quite unique in its way, and because and the first point was the change in collagen to me is secondary to the rubbing. And if you have one eye with Keratoconus and the other eye has no Keratoconus, anytime, every time there's unilateral Keratoconus, there's unilateral rubbing, it's almost like an evidence of the mechanism in action. Because if you remove rubbing, that's what happens on the other eye, there's no Keratoconus. So there's a lot of logic there, and it's difficult to prove scientifically like in mathematics, but I wish my contradictor come with a theory which from A to Z makes the cornea steep, focally thin, and deformed like it is in Keratoconus. But it never happened yet, so I'm still puzzled by that. You muted, Miltus.
You have a good argument on that, and I have followed a lot in our specialist meetings this kind of discussion between you and other members, and I think it relies a little bit in the middle, and I'm more in favor of the mechanical the more I grow older and with more white hair, I think.
Yeah. What is important, because some people come to me and say you're stupid, because I know many people who rub their eye and they don't have Keratoconus. Of course, it's like I know many people, they go to the beach like in Greece and they don't have a sunburn.
Yeah, I agree.
If you rub, you won't always have the Keratoconus. But if you exceed some threshold, then you have it. That's my point. It's not bilateral, right? It's a unilateral relationship, causal relationship to me.
Well, if I may add, I think it's like the egg and the chicken concept. Sometimes after surgery, after cross-linking and corneal rings, the keratoconic patients, they admit they are rubbing less the eye. Of course, we have educated them, we have talked to them that eye rubbing is very bad, but I do believe that when we treat keratoconus and we decrease the protrusion, eventually the impact of the eye rubbing sensation that the patient has will be decreased somehow. So keratoconus, while it advances, is like a vicious cycle that aggravates eye rubbing. So once we understand that, people that have the keratoconus treated, somehow they will have less eager to have eye rubbing. So it's very important that we understand this concept as well. So it's a kind of cause and consequence. And if I may add also, we have tacrolimus, which is a very important anti-inflammatory that gives you the ability to reduce inflammation with lower risk of glaucoma and cataract, as we have with steroids. So it's interesting to have this on your armamentarium for clinical treatment, along with other anti-inflammatory like cyclosporin. And least but not less important is the riboflavin orally. So I'd like to ask you, are you using oral riboflavin, Damien and Mitos? What do you think about that?
Me, I don't use riboflavin even technically, because if I follow my theory, I don't believe cross-linking per se is the appropriate therapy, although I agree with you that when it makes the patient stopping the rubbing, it's good. So on that, I'm really happy that people have a good success with that. But I believe it's attributed more to the cessation of rubbing than the stiffening of the cornea. And I think that's important what you say. You have to break the vicious circle of inflammation leading to rubbing, leading to inflammation. And also there's sometimes less inflammation after some months after the cross-linking. And what has not been said is also to have a eye protection at night, to also break the inflammation, because we suspect that the role of the rubbing of the sheets, of the pillows, of the hands at night is probably a very important hidden causative factor for inflammation, etc. So having in children especially some like a goggle shields for night is quite interesting, and it helps sometimes patients to realize they rub unconsciously while they sleep, which is good also to realize. Do you use
the damage that you do with cross-linking on the corneal nerves play a role on the stop of the eye rubbing? Maybe they don't feel so much this triggering effect that they want to rub the eyes, or maybe we have passed the message better. We do use tacrolimus in off-label treatments, but unfortunately we don't have the tacrolimus from the Japanese, I think, drops from Sandoz. I don't remember. Anyway, we don't have these drops in Greece. We hope that we'll have them in a year or two to come. And we don't have at the moment oral riboflavin to use at the moment. I don't know. I have no experience on that.
Yeah, one other thing that we have is the ability to improve ocular surface. So we have seen some patients that have done IPL, the intense pulse light therapy, for dry eye. And I do believe if we do more treatment in the temporal area, we may have an impact on reducing eye rubbing. But this is still a hypothesis. We are starting to do some of these treatments to improve the sensation of eye rubbing, along with the treatment for ocular surface for meibomian gland disease. So we have a lot of opportunities to tell people not to rub the eye, and eventually to treat them for reducing the eager for eye rubbing, because eye rubbing is hard, because people are really addicted to the eye rubbing. They feel very good. They feel pleasure with eye rubbing. So having people not to rub the eye is a complex situation, because you need to do a psychological. It's like being addicted to a drug. People have to be treated for that. It's not so simple and stop your rubbing the eye. It's a complex thing. So we have to acknowledge that eye rubbing is very important, and telling the patient not to rub the eye is not so simple.
Absolutely. We have another question on twins. Does anyone want to comment on twins and keratoconus? At least I have a few twins with keratoconus as a patients, but I don't think that necessarily when one of the twins has keratoconus, the other one will have. I'm not sure whether this happens on monozygotes, but certainly there are published papers with twins where one of the twin had keratoconus and the other didn't have. I don't know if anyone else wants to share any of these experiences on that.
We have a very good journal, the International Journal of Keratoconus and Aesthetic Diseases. This journal has a lot of good publications. Many of the publications that Damian shared in his talk were from this book, is this journal. And one of the articles we published there is a twin sister that came with a very asymmetric disease. And Damian has used this model for very asymmetric cases for demonstrating that the fellow eye with normal topography have some early changes on tomography, and now we have biomechanics. Even wavefront can change with that. But the second twin sister was very interesting because she had both eyes normal. And both eyes normal, and then we would say exactly like that. So this twin sister demonstrate that this is not genetic. This is truly one of the ways of demonstrating genetic role in a disease. But interestingly, when you go deeper on the understanding of the disease, like the TBI in the four eyes of these four genes, the four eyes with the same genes, the TBI is abnormal, the tomography and biomechanical index, and this is published. So we are convinced that the first twin sister with a very asymmetric ectasia presentation, she has more keratoconus in the right eye because she rubbed more the right eye. The second twin sister does not have keratoconus. She has bilateral normal topography because she did not rub the eye, and that's pretty much consistent with their history. Interesting, we took the genes and sent to one of the companies that do genetic testing, and they pretty much concluded that they are twins. So that's the only thing that we have from the genetic testing. They proved that, they confirmed they are twin sisters. They have 99% of being twin sisters. So we don't have like a gene that is found somewhere, but those cases are the ones that we have to really collect. I have patients that are brothers and sisters, and one has keratoconus and the other does not. I have patients that had one brother and sister or sister had ectasia after LASIK, and we did PRK or LASIK in the other brother, and they are fine for 5-10 years. I'm sure Damian has the same, and you have the same experience as well. But this is definitely a multifactorial and combines the genes with the environment.
Well, we follow more than 25 families in the region. And what we see is that in some cases we have some members of the family with thin corneas, but no cone at all, and some other members with keratoconus. So I think thin cornea can be somehow a signal, and then someone will develop keratoconus, someone may not. And also we have some cases where we have coexistence of 2 or 3 dystrophies. Posterior polymorphosis is one. Posterior polymorphosis is one that we see quite often. Fuchs as well. And the other interesting thing is that we have 2 cases where they have macular dystrophy and keratoconus in 2 brothers. So okay, it's too complicated because there are so many factors, so many genes related to all these patients. But I think twins are crystal clear what's happening. And to answer the question, yes, not all the twins will have it. And there is another question about Massimo Lombardi's keratoconus. The cause of keratoconus might be fungal, and I think you want to discuss on that. Does anyone? I've been to. I just remember that he.
Don't rub your eye.
Sorry. Yeah, I mean,
don't rub your eye.
The question is, I cannot. After all this eye rubbing, I have to do something. But I think I'm too old to develop it. The question was not that aspergillus is the pathogenesis keratoconus aspergillus. What he was mentioning was that during the embryogenesis, usually it resembles, aspergillus resembles the keratoconus in a sense that usually has does go into the thinnest location of the thinnest part of the cornea, and that's why he made the connection that it may be fungal the cause of keratoconus. I think there is a lot of discussion. It's just another one of the theories that we have seen. I have to look it up, and I certainly cannot do that now. But if I can, I can try to answer tomorrow, or maybe a bit out. So that's all I remember from this. Sorry about this. It's one of our doctors from the audience who asked that. So, Dimitris, let's move on, and Dimitris will have another more complete look of how we developed cross-linking and how we're using cross-linking in various aspects of the disease. Dimitri.
Good evening from Thessaloniki. Are we okay with my presentation? Is it visible? Okay. I would like to thank all the international faculty that joined this live event organized by our clinic. Their talks were exceptional. They are rightfully considered as gurus on keratoconus. We have entered the era of webinars for good, and I will attempt to make an introduction of the principles of cross-linking in simple words. Back a few years ago, when I cracked my brand new car's windshield, although I was insured for that, I searched the internet and found a video that uses a glue on the crack, and then it uses some UV radiation to polymerize the glue and integrate with the glass fibers. And this is how you repair a crack the easy way. Now, imagine that the cornea is actually the windshield of the eye, and that has a weak spot that has keratoconus, and you want to repair it without changing the whole windshield. And I think that is exactly what cross-linking tries to do, put some glue on the weak spot on the cornea and stop the damage. So cross-linking is a technique that tries to strengthen the weak ectatic cornea, normalizes the shape of the cornea, and the ultimate goal is to stop the progression of the keratoconus, because as we know, keratoconus is a progressive disease, and this is what makes this difficult with it. Because definitely the biggest and loudest revolution in the treatment of keratoconus in the 21st century, and it was actually the first time that we felt that we as clinicians can do something to stop the progression. The idea of stiffening the tissue is not a new one. It goes back to 1964 or even further, but came into actual application for the eye in the late 90s from Theo Zeiler and Eberhard Sprull from Dresden. And here's where the journey, here's where the trip begins from Dresden. And the idea is to strengthen the weak collagen fibers of the keratoconic cornea. In other words, to put some glue in it and make it stronger. Cross-linking has three basic components: riboflavin, UVA radiation, and oxygen. And if you combine them in a magic way that you create what we call the cross-linking effect, and how do you achieve that? By radiating riboflavin with UVA radiation, it falls into a chemically unstable state of triplet molecule that creates free oxygen radicals that have a chemical interaction with the collagen of the cornea or the proteoglycan matrix of them, making it stiffer and stronger. The original technique is pretty much what we see in the video, where the superficial layer of the cornea, called the epithelium, is scraped off, and then we instill drops of riboflavin every 2 minutes for half an hour, and then we irradiate the cornea with UVA radiation for another half an hour. And as every surgical intervention, cross-linking has its own indication, as we can see here. But even this indication, as ophthalmology progresses, are debatable and under negotiation the whole time. Definitely, there are concerns for the safety of this procedure, and that's why it's a job under constant development. And we set very strict safety protocols for the benefit of the patient. But it has shown clear advantages. It reinforces the biomechanical properties of the cornea. It stops the progression of the keratoconus, and it can even offer better vision by reducing the higher aberrations and especially the coma. The tissue stability and corneal rigidity increases sometimes spectacularly, and we see the fine-tuning that it does in the topography. So the original classic Dresden protocol 30 minutes has evolved in the course of the time. Now we have shorter, accelerated protocols, more efficient, and quite recently customized protocols tailored for each patient individually. We now have accelerated techniques that don't require the removal of the epithelium, so we have better and faster healing of the cornea. Or we can combine cross-linking with other methods like the excimer or the intrastromal rigs to give a better quality of vision if and when possible. We still have unanswered questions regarding the cross-linking, and the question of the truth isn't over yet. And maybe the biggest of all is, what is actually the cross-linking effect and how long does it last? And what is this demarcation line that we see in an OCT post-operatively? Is this line indeed a sign of success? We still discover things and adapt and evolve our methods and techniques, but it is surely a technique that has reserved spot in the algorithm of the global consensus in keratoconus, as we see here in the algorithm. Cross-linking has definitely skipped the stage of being an experiment. It's been around in ophthalmology for over 20 years, and I think it's time for a refinement. It's time for some fine-tuning. And this refinement in our days is the customized cross-linking. What makes it different from the classic cross-linking is that it focuses on the strongest part of the energy on the weakest part of the cornea, the one with the bigger problem, sparing the rest of the tissue that doesn't need so much radiation. In other words, it's a customized approach where we adjust the intensity and the position of the treatment in the different parts of the cornea, treating the weaker parts with more energy and the healthier parts with less energy. With the help of the topography, we identify the parts of the cornea with the biggest problem, and we design 3 circles of energy, a small one with greater intensity and 2 larger circles with less intensity as we move away from the conus to the periphery. This is a more logical approach. There is no need to remove the epithelium and the healing is faster. So we have the topography, we have the surgical plan, and we're trying to combine them in a smart and efficient way. This is a nice set of faucet images of what we want to achieve with this technique. Different intensity and depth of treatment in the different parts of the cornea. Mitos will elaborate later on more on this subject. This is a short video of how you design the treatment on the spot, on the fly. We designed the first circle focusing on the posterior elevation, where we believe is actually the main issue, the biggest problem. As we move on, we design larger circles as we move to the periphery. As you can see right here, we make a second circle with less energy because the problem is less and we need less energy. And we can design any kind of shapes, circle, ellipsoid, even free design with the tip of the finger. So easy and so direct and so straightforward. Theo Zeiler gave us the first guidelines on how to use this new modality. We started in 2018 with 18 eyes, and our experience has grown with more than 215 eyes, some nice OCT and shine film images pre-op and post-op, deep demarcation lines. We take it as granted that this is a success sign, so deep demarcation line that goes down to the 346 microns. Sometimes, whenever it's possible, you can go even further. You can combine cross-linking with a wavefront guided excimer ablation in order to reduce hydro aberrations and especially the coma, and try to improve the quality of the vision. And by making some careful but nevertheless wise decisions and choices, the end result can be really impressive in terms of quality of vision. No doubt, the customized approach has more major advantages because it respects the health parts of the cornea. You can treat thin corneas by adjusting the amount of the energy delivered on the conus, and you have a faster healing of the cornea. Sometimes you don't have to replace the whole windshield. All you have to do is to put some glue on it and fix it on the spot. If you are still with us, thank you for your attention.
Dimitri, we have more than 168 attendants, so I think there are quite a few people with us, and I would like to open up again all the esteemed speakers that we have, both Damien and Renato. We have another couple of questions. I would like to skip a little bit the eye rubbing because I know that Damien is fed up with trying to answer again and again. Yes, of course, he has shown that can be reversed once you stop it. I think if you follow some of your early talks, you showed cases where there was a reversibility, or at least there was an improvement after stopping. And as eye rubbing happens at any age, okay, let's move it on. The Epion question, I will answer it when we will have the talk. And if you don't rub your eyes, but you press them from the bottom in the white area, okay, I think nobody really rubs like that. If you have, I don't know, maybe in Brazil, do you rub your eyes that way or that way, Renato? You rub it that way. So,
well, I think it's across the world. People rub their eyes based on how they have the eager to. People, when they rub with the knuckles, they are much worse. And I tell them the simple way to teach them to rub the eyes in such a less gentle way is when just they rub against the caruncle. If you just pressure the caruncle, you release the eager for, so it's okay for you, and you don't pressurize the eye. So I think that's the main tip that I may share with you. And also, sleep over the eye is very bad. Some obese patients, especially when they are older, that we don't anticipate more progression. If they sleep over the eye, especially over the hand, they probably has much more problems. And those are the patients that fail the treatments of cross-linking and rings.
In Greece, we don't have that many eye rubbers, but a tip that I give to the parents when they do have is to put a cold, some sort of cold bandage or something really cold and moist, and it will relieve some of the aspect of the pain and of the itching that they feel. So before they go to bed, they just have this kind of cold bandage for 10 minutes or so, and usually that stops them from rubbing. I mean, that's what the mothers tell me, and I think cold is another interesting thing to use when you have allergy. Cold is a friend against the fight of allergy. A cold epithet.
If you have people who cannot stop, sometimes we show them the video of the MRI because they say, oh, no. And that's very efficient, especially for the children or even children. When they look at it, they say, wow, that's what I'm doing to my eyes when I do it. I'd better stop. And that works.
This video really is fantastic. Really is fantastic.
I agree. Great contribution.
Another aspect that I want to share is sometimes we notice that the frequency of eye rubbing after cross-linking is reduced. And I don't attribute that only to because it reduces the inflammation or the treatment reduces inflammation, cross-linking reduces inflammation. But the patients themselves try to respect the operated eye. They think that they've done something to that, so I have to be cautious with that. So they stop rubbing it. And this is a switch of the behavior, of the attitude towards that.
Psychology as well. So, and there is another interesting question about contact and this may play in the contact lenses, especially when they coexist with some degree of dry eye. How do you feel about? Do you believe that contact lenses play a role in aggravating the disease? Plus or minus dry eye, what do you feel?
That's a great point. We have the consensus today, published in 2015 in the Cornea Journal, that pretty much we agree as experts in terms of the role of contact lens. The contact lens fitting gives you the best opportunity to improve patients' vision. As much as irregular the cornea is, the more benefit the contact lens will give you. And likely the cases with keratoconus, the more advanced they are, when you fit a nice contact lens, they have a huge benefit from improving vision. With that said, the benefit for reducing the progression of keratoconus is something we agree that does not exist from contact lens. On the opposite, if the contact lens is not well fit, it aggravates keratoconus progression. So it's also a consensus that if the patients with keratoconus have good vision with glasses, the cosmetic use for contact lenses should be taken with very careful. So it's a debate if the contact lens helps with the progression. We agree not. And if the patients with keratoconus, if they have good vision with glasses, if they can fit a nicely fit contact lens, I think it's very adequate. But you have to follow these patients no matter what. So the contact lens issue is very important because some colleagues that do contact lenses, they tend to give the patients the promise that contact lens fitting will help them in the progression. I think it's unfortunately not the case. Unfortunately, because it would be great if it is the case.
I agree, and I could take this point a little bit further. We, as well as our contact lens fitting department, we are changing the way we're fitting the contact lenses now, and we are strongly against fitting on the cone, because I think the mechanical effect that you have is the same as the mechanical effect that you have with eye rubbing. You're just pressing mechanical pressure on the weakest area, and that certainly make the weakest area even weaker. So now we are fitting more and more scleral lenses where we try to avoid any touch on the cornea, and also some kind of lenses where we try to avoid any touch, at least on the cone. That, unfortunately, cannot give this kind of excellent vision in highly aberrated eyes, but at least it can control, or it can treat the refractive element of spherical myopia and all that, and improve slightly the coma that they're inevitably had. But on the other hand, we keep the cornea as far away from the plastic of the contact lens, which I do believe it played an important role in the development of the progression of the cone. I don't know, Damien, what do you think about that?
Yes, I think it's very important to fit contact lenses with the most care, and this should be done by someone who's like used to fit these specific patient. Also, to avoid to induce problem if the contact lens is not well fit. So it has to be very well done, and we like scleral lenses for that, because they provide sometimes some relief because of the solution that you have to put in, and it's quite, I think, good in dramatic cases in particular.
Mm-hmm. Dimitri, do you want to add anything on the contact lens fitting?
Well, definitely it has its own unique spot on the algorithm of the global consensus. After cross-linking, the best modality in order to have a better vision is to fit a proper, specially designed keratoconic lenses. We don't go straight to ablation. We go straight to intrastromal secondary rings, but you need definitely a specialist in order to do so. Not only scleral contact lenses do not touch the cone, but also hybrid designs that have a very stiff periphery and a very soft central part that don't touch the cone can give excellent results. Now the tendency is to give to create an artificial lens from water or from your own tear or meniscus, to create a second tear meniscus in order to make a second lens in order to give a better vision on that.
I think we have to, exactly, we're expecting more news on the contact lenses industry on that aspect. And the more we have, the better contact lenses we have, the better results we have. I would like to move on my own presentation, since it will also answer some of the stuff that has been asked to. I don't know if you can see my presentation. I think now we are about to have this. Dimitri, can we see the presentation? Is it okay? Yes, can I start? Okay, I'm starting. So, this last part is a talk about changing slightly the paradigm, at least now that we have in our hands beautiful equipment that can make life easier for us when we treat keratoconus. We used to remove epithelium, and when you remove epithelium, some things are not in your favor, like you're delayed the healing when you do cross-linking as well. You may have sterile infiltrates, and you may have infectious keratitis, and you certainly have a little bit or even more significant scarring or corneal haze. But when you take the epithelium off, certainly you have a more efficacious way to treat the cross-linking. All the randomized control trials have shown that standard cross-linking is much better and more effective than the transepithelial one in all the aspects. But we were missing something there. And what we were missing, another element that we were missing when we were treating cross-linking was oxygen. We have UV, we had a photosensitizer, but we didn't consider oxygen in the beginning as a major player when we treat patients, especially when we decide to treat transepithelial cases. And also, we didn't know about that much about oxygen-mediated and non-oxygen-mediated pathways. And the oxygen-mediated pathway, the type 2, was the most important in an effective aspect in the change of collagen in the cross-linking. But unfortunately, when we do cross-linking, oxygen consumption is rapid within the first seconds, within less than a minute. And then you have type 1, the non-oxygen mediated type of cross-linking for more or less 10 minutes. So we had somehow to change this and to have more hyperoxic environment when we do cross-linking. And that can be done when we have an environment with 90 or even 95% oxygen around the eye when we do the cross-linking. And we do that by using this device, which is a device linked with, connected with oxygen. These goggles can improve dramatically, as you can see, the way we do cross-linking. Adding on that, the customized cross-linking that we're using, and Dimitri had described before, the way you do customization in any form and any shape you would like. This is the first protocol that we use with the 3 circles. So we put all that, riboflavin, special riboflavin, oxygen goggles, and pulse-targeted UVA. You can have this new treatment, this new thing that we are adding now into our way that we treat cross-linking. And the results of the first study showed a very impressive improvement on the best corrected visual acuity, as you can see on the right. Kmax reduction similar to the standard epi-off procedures, and demarcation line as deep as the standard epi-off procedures. Here in the demarcation line, you can see that this is the first circle where we use the most energy, and the demarcation line goes as much as 3/4 or 350 microns deep. And you have the second level of energy and the outer circle in the periphery. The demarcation lines of our patients, as you can see, there were 24 eyes, and all the eyes were above 220. And the mean demarcation line depth was 352, exactly the same as the standard cross-linking mean demarcation line that we have in our original Dresden protocol. So we do that in cases. Here's one case, a 19-year-old student with keratoconus. We did an epion curve on the wear side. You can see on the difference, marked flattening here, 6 months after the case. And this is a comparison between 3 to 6 months, and you can see that they're developing the change of the collagen, which happens even 1 year. Unfortunately, the eye that we didn't treat at that time, the untreated eye, developed thinning. And this remarkable thinning, of course, leads us to do cross-linking on the other eye as fast as we can. And these are the appearances of the eyes after cross-linking. You can see the central area, the more peripheral ones that we do cross-linking. This is another interesting case, a 12-year-old boy. You can see the marked flattening. So we can do safely epion on our little fellows with keratoconus and stop the disease. This is a marked flattening So customization plays an important role. We can still looking for better strategies with different plans, different energies, and hope by changing that we can have even a stronger cross-linking effect. And this happens because we have the ability now with this new equipment by Avidro. But okay, let's try to think how we are going to take all these advantages of the new technologies that we have, like cross-linking, the intracorneal rings and all that, and adapt them in the cases that we have in front of us in all these keratoconic patients. I think there are 4 aspects which play an important role on this. This is the corrected visual acuity, the thickness of the cornea, the amount of coma or the RMS, and the progression, which in that case is basically the age of the patient. So when we have thick corneas with good visual acuity, I think that just Epion curve will be good enough when you have low RMS, or if you have high RMS, high coma, and the visual acuity, the corrected visual acuity is not as good as in the other cases, you can improve the shape of the cornea, the anterior surface of the cornea with topo PRK or with intracorneal rings, and add, of course, cross-linking. In cases of thin corneas, but in thick corneas, but even poorer visual acuity into the level of 410 or 210, then of course we have to consider dark. You may again try to do topo PRK or even combine it with customized cross-linking to have more of the effect on changing the shape of the cornea. And of course, as we said with the previous one, you can try intracorneal rings, but topographic PRK and intracorneal rings in these cases, usually they're a little bit of more unpredictable as in other cases. And I think the lower the visual acuity, the best the candidate for deep anterior lamellar keratoplasty. In thin corneas, I think Epion in these cases with the low RMS is a very good case because you can still use the cornea that you have and the epithelium as a safety margin for doing cross-linking in cases that you otherwise couldn't do because the stroma was too thin. But when you are having very low visual acuity, Epion curve is not going to help you. I think these are again cases of a deep anterior lamellar keratoplasty. And I would like to thank you with that. And this was my presentation. And of course, I'm sure that this presentation will create a lot of discussion with our friends. Damien and Renato, you're still here. Good. We still have a few minutes. I know that this presentation, the last presentation, created a little bit of discussion. So I'm happy to have you and discuss all these changes that we have now into our armamentarium. Renato, what do you think?
Congratulations for your talk. I am learning a lot about the new KXL2. I don't have I do use the KXL1, and other cross-linking machines that are available here in Brazil. I am very much positive that the Epion cross-linking is the way to go, because when we started talking about cross-linking, people would say that cross-linking is like a vaccine to treat the patient before the disease comes. And in terms of the concept of the vaccine, the treatment cannot be worse than the disease. So if you do cross-linking in a patient with the Epi-off Dresden protocol in a patient that does not need the cross-linking procedure, you may cause more harm than benefit. Epion is different. And I do believe that Epion has the great clue for the surgeon, which is the epithelium. So the epithelium is going to mask the UV and blocking in the area that is thicker. In the thinner epithelium, which is likely the places that you need to have more cross-linking because of the epithelial mapping, as we see with the OCT technologies, we believe that the epithelium is going to be the best customization protocol, as we do for the transepithelial PTK for therapeutic cases, and in which you later use some masking agent like the Paulo Vinciguerra technique. So I think the Epi-on is the way to go, and I'm very happy to see your experience, Kamasota experience as well, and all the movement towards the Epi-on, because we'll be able to expand the opportunity to treat the patients in an early fashion in a more safer way. And it doesn't give you less the importance of the eye rubbing, of course, but cross-linking Epi-on is definitely the way to go. And I'm very happy to see the nice results that you shared, which is pretty much in agreement with the ways I do Epi-on as well. But it's still a little bit of more art than a true standardized scientific proven procedure.
So
Yes, Damien, yes, you want to add something, Damien?
what is your share between epi off and epi on today? What is your approach?
I have to tell you that we have this 2-year follow-up of most of these patients, and these are the results that we have, the paper that we have sent to Journal of Cataract and Refractive. At the moment, I can tell you that it's about 50 to 60% of the cases that I do are epi-on cases.
Mm-hmm.
And I leave epi-off only in the cases that I have severe RMS change, severe coma, and severe low visual acuity, and I want to change slightly the coma. So by using the splint, I'm trying to relocate as much ablation at the coma, at the cone, but not too much. And in cases that I have a good visual acuity, the level of 7 out of 10 or 6 out of 10, I just do curve and epi-on. And it does change a lot and does improve the visual acuity. And it was a surprise for me. It was a surprise. And the other important thing that we have in the paper, I didn't want to spend too much time on this on the talk, is that we have a correlation between demarcation line percentage on the cornea and improvement of visual acuity. So this is something that tells you that, yes, we may be able to have a deeper penetration, but a more effective penetration, which does improve the visual acuity. I don't know. It is not preliminary data. These are cases that we have. Most of them we have also about 2 years follow-up, and it's and they're about 25 eyes. Now I have done more than 50 cases on that. So I do use it a lot. And it's also fantastic for the children. You know, when you have children, it was always a bit of a puzzle whether you could use epi-off procedures. It was a bit difficult to have the contact lens. Now with this epi-on, I think you will have the effect of the standard protocol without removing the epithelium, and this for me is fantastic. And we do have a lot of pediatric cases.
Interesting.
This is interesting because I do follow the Greek from John Kanellopoulos and Giorgio Chimione on the Athens and the Cretan protocols. The difference is if you do PTK only or if you do some form of topo-guided or tomo-guided ablation. I think the topo-guided ablation is a great tool, but eventually with just the PTK, as you just described, just do the PTK removal is the best way to remove the epithelium. So, but if you don't need to remove the epithelium will be even better. So the Epi-on is definitely the way to go, and we are all moving towards this as an efficient cross-linking with the Epi-on protocol. Very, very nice.
We were doing the John Kanellopoulos procedure. John is a very good friend of mine for many years. But we all had patients that trouble us. We didn't understand why they didn't go as expected. And I mean, I do understand, because cross-linking can be sometimes unpredictable, even if you do it in the same time with PRK, or let's say because you're doing it in the same time with PRK, and also
I have a question, actually a comment from a friend that just sent me on the WhatsApp about the combination of PRK and cross-linking as a prophylactic procedure. I would say that's probably one of the most important misunderstandings of people, because cross-linking is not like a prophylactic antibiotic for preventing infection that you don't want. So just doing everybody and then you prevent ectasia, which is a very bad complication. If you do cross-linking along with surface ablation as a refractive procedure, I think then you have exactly what you just described, very unpredictable results with severe flattening over time, irregularity, and those patients, they do very bad. So I think cross-linking is something that is needed when you have a therapeutic procedure for ectatic corneas. And if you have a borderline cornea, you may even consider not doing a cornea refractive surgery, but a phakic IOL, which is going to be safer in terms of an elective procedure. So that's why I do compare the lion and the cat. They have a lot of similarities. Surface ablation is surface ablation, but surface ablation, a patient that wants to get rid of myopia glasses, is different than patients that don't see well with glasses and need some transplant eventually. So those are different situations, and we have to acknowledge that.
You know, Renato, once you have a case of cross-linking that you did PRK cross-linking and they end up with +5 of hyperopia, then you start regretting of doing the combination. Yes. And we all have these kind of cases that end up with a hyperopic result throughout the years. Dimitri, we have Vasilis Liarakos with us.
Yes.
We all know Vasilis.
I just want to comment on what we said about the combined. It's a very selective. It's not for everybody. A patient with keratoconus has to understand what the problem is. It's not the refraction, it's the instability of the cornea. And our concern is to do something to stop this progression, not to give, per se, a better quality of vision. This will follow. And if there are good circumstances to follow, then we may proceed further on to do something additive, in addition, a PRK ablation, excimer ablation, or to put some intracorneal rings. But the main concern is to understand what the problem is, to stop the progression, to have a better cornea, and if we have the ability to offer a better quality of vision, no matter how and no matter what, we will do it.
True. This, of course, Dimitri, this all is in the ideal world. Sometimes our patients are impatient and they want everything to be fitted in one operation. We have to guide them in a certain way. So we have an interesting case. I would like to say hello to Vasily. Unfortunately, we cannot see him, but he sent his congratulations, and he has an interesting question. How would you approach progressive corneal thinning of the post-keratoconic cornea after an old penetrating keratoplasty for keratoconus, especially when it affects the graft-host junction area and the thinning is below 300 microns? This, a bad case. So pick up your brains. Whoever wants to start answering this question.
Well, I will answer this question, and then I unfortunately have to leave because I need to get my kids at school. This is my day of getting my kids at school. So
we are very lucky to go to school.
Do they go to school?
We have them at home. We have them at home quarantined.
It's been a month ago, then they started coming back, and they don't know until when it's going to last. But it's a crazy world now. But going back to the case, if you have a peripheral thinning, that's what I say is a recurrent keratoconus or a recurrent ectasia after penetrating keratoplasty. It typically occurs in patients with advanced keratoconus that rub the eye a lot, and I think it's a recurrent of ectasia because you see the thinning in the patient's cornea, and the transplant is very thick. So what I typically do in those cases, I I use now the femtosecond laser to refine the cornea and have a little in towards the patient's cornea, towards the limbus, and then I suture with a topoplasty that I learned from my professor, Dr. Sivintal. And this is published in the Brazilian Journal of Ophthalmology, and it's very easy. If you do topoplasty and put my name, T-O-P-O-plasty, topoplasty, you just retrefine and do suture. I have a friend that does retrefine with a blade, go inside the eye, and then he rotates 45 to 90 degrees and saves the cornea. And the possibility of having this as a best procedure is because most of these cases, the endothelium is very nicely in an immune tolerance with the host. So it's a very nice idea to keep that cornea if the cornea is transparent. A corneal ring is also possible, but you need to see the thickness in the periphery so that you are sure if it's possible or not. So this is a very interesting situation. I have seen Seiler showing the peripheral cross-linking in an annular fashion for cases like this one, but some of these cases are very thin. They are like 345, less than 400 in the periphery. So I think the suture is probably one of the best ways, and eventually having a little bit of tissue out along with this dissection may be a good idea as well.
I agree with what Renato said. You can also try tectonic graft in addition to the previous graft. I've seen cases like that, but there are risks of rejection and inflammation. But in some case, when the thinning comes to be very, very thin, that's all you have to do is like a patch of a stromal cornea that you can find on a bad donor, for example, or something like that, and then you can tailor it to the shape you want and put it like a little inferior bandage at the junction, and that
like
may
a little banana. Let's do a little of a banana-shaped kind of cornea. Yeah, that is a big. I mean, I had a similar case where there was not a keratoconus.
You had with a pellucid when we put a banana-shaped intrastromally piece of cornea in order to strengthen the periphery of the thinning of the peripheral thinning.
Instead of cutting the whole thing, I just make a pocket, put a little bit like 200 microns or 150 microns of stroma in the thinnest area, then put a suture at the paracentesis, and that's all, and makes this little area a little bit stronger. But you know, I don't know whether this will hold the whole situation, but in some cases may work. I have Googled your topoplasty, and I will have a look.
Me too. I've done it here. It's very
okay, guys. I'm sorry, I will have to go.
Yes, everybody has to go. I think.
Thank you very much. I think we certainly enjoyed that, and the audience enjoyed that. Hopefully, in the years to come, we join ourselves strong and in a personal manner. Thank you very much, Paris. Thank you very much, Brazil, and thank you, Siena. Bye bye.
Thank you again.
Bye bye.
Bye bye.
Στο νέο KXL έχουμε προσθέσει μια οθόνη αφής υψηλής ευκρίνειας, η οποία είναι μεγαλύτερη από την προηγούμενη έκδοση. Το λογισμικό επιτρέπει τροποποίηση των πρωτοκόλων και σύνταξη γνωμάτευσης, η οποία μέσω USB μπορεί να μεταφερθεί στον υπολογιστή σας σε μορφή PDF για αποθήκευση και εκτύπωση. Το KXL της Avendro επιτρέπει στο χειριστή να πάρει τα αποτυπώματα του κερατοειδούς και με βάση αυτά να κάνει εστιακές εφαρμογές σε περιόδους ακτινοβολίας ακριβώς στα σημεία που έχει ανάγκη ο κερατοειδής. Μελέτες που έχουν γίνει με βάση το KXL σημειώνουν σημαντικά αποτελέσματα στην αποπλάτυνση και επιπέδωση του κερατοειδούς μετά από cross-linking, καθώς και την αλλαγή στο διαθλαστικό αποτέλεσμα. Με άλλα λόγια, οι ασθενείς μπορούν ταυτόχρονα να σταθεροποιήσουν τον κερατόκονό τους και να βελτιώσουν την όρασή τους. Οφθαλμίατροι με εμπειρία στην πάθηση του κερατόκονου και στη διασύνδεση κολαγόνου υποστηρίζουν ότι τα αποτελέσματα της επέμβασης μετά τη χρήση του KXL είναι απολύτως σταθερά, με το 99% των ασθενών να έχουν σταθεροποίηση του κερατόκονου και αλλαγές στο διαθλαστικό σφάλμα για τα πρώτα 2 με 3 χρόνια.